So in this lecture, I'll be talking about prescription opiate dependence, which, speaking to GP colleagues, I know is and is becoming increasingly a problem. The subtitle: Why is it so common? And some thoughts on management. I don't claim to come up with any solutions. Okay, so we'll press on with this. So what's happening in the US? I think we've all heard about the opioid epidemic, and this has been increasing over the last after the last 30 years or so, and it was really brought on by the mass production and promotion of synthetic opioids. The one you'll particularly have heard of is OxyContin, oxys, or oxycodone, or hillbilly heroin. I don't know if that's a term that you've heard. So it's a lot cheaper than heroin. So these drugs in the States and in other countries have led to significant levels of dependence, abuse, and a significantly increased rate of opiate deaths. So oxycodone is a powerful opiate with a significant risk of overdose. So what's happening in the UK? These are just some figures that I pulled from a paper in a general practice journal about what's happening in the north of the country in Bolton. So a considerable amount of opiate prescribing is going on. And as you might expect, with the increased levels of prescribing and use, there has been an increase in deaths from prescribed opiates, particularly the stronger opiates such as fentanyl, oxycodone and tramadol, in particular when these are taken with alcohol or with other drugs. And this is a problem that's worldwide. We know that over-the-counter products have been long available. Most of these contain codeine preparations. So with paracetamol, it tends to be 8 milligrams. With Nurofen, it's 12.5 milligrams. And it's something that patients know. I don't know, have you heard of the cold water extraction technique? No. So there is a relatively easy and straightforward way of separating the paracetamol from the codeine and just making a codeine mixture. And I think pharmacists know about this a lot more when patients will go around and buy, can I have 4 packs of Codebol, please? So this is OxyContin. This is taken from a CNN website. An estimated 10.3 million Americans misusing opioids. Now the vast majority are prescription opioids rather than heroin users. The medical system, as you know, is different in the States, and it's probably rather easier to get a prescription in America than it is here. But here in the UK, we're seeing an increased amount of prescription medications. So this is taken from an article in a general practice medication, and it asks this question: are these medications useful in chronic pain? And the answer is that essentially the answer is no. These medications are not useful. There have been quite a few studies in which patients are randomly given their opioids are replaced with placebos, and the patients cannot tell whether they've been receiving placebos or opiates after a while. So why then do these patients continue to take them when there's little benefit and they suffer from side effects? So in the paper, these were the two main reasons that the author gave, which on the surface you can see that they seem plausible and sensible. I would suggest that the number of patients who are using in an addictive rather than a dependent way is relatively small. What I would like to suggest is often overlooked is that these opiates that are prescribed to lots of patients are useful to manage anxiety, in inverted commas, just to help people cope with life. And I think this is overlooked. I'm going to go off on slightly off on a tangent here and talk about why this might be happening. And I'm going to talk here about some of the concepts and how we conceptualize what we now call anxiety and depression, and how this came about and how this was previously viewed. So in earlier versions of the DSM-I and DSM-II, non-psychotic depression, so not manic depression, these were characterized as neurosis or personality disorder. And in DSM-I, they were listed as a psychoneurosis or a cyclothymic personality with a depressive subtype. And in DSM-II, the term depressive neurosis was used significantly. And there were two other categories, namely neurasthenic neurosis and asthenic personality disorder. Have you heard of these terms before? Okay, so very few people will have heard of these terms. Now, I'm going to tell you what these terms were, and you can have a think about whether these might still apply to a number of patients that you see in primary care. So neurasthenic neurosis, with weakness and fatigue stemming from chronic overwork brought on by attempts to compensate for low self-esteem and the lack of primary coping techniques. So pretty brutal as a definition, but I think that you can see patients to whom this definition might apply. Yes, no? Okay. Now, again, hard-hitting, asthenic personality disorder, low energy, easy fatigability, incapacity for enjoyment, lack of enthusiasm, and oversensitivity to physical and emotional stress. So, you can see a lot of this in primary care, and the primary care presentation of "I'm tired all the time," is very common. And what has happened is that all of these patients now get labelled as being depressed and given an SSRI. Would you say? So things changed with the DSM-III, and as a result of this change, the whole of Western psychiatry changed, and that's not an exaggeration. So depressive neurosis that we've seen defined was completely left out of the DSM-III, and there are various political reasons for this, or territory fighting between the biological and the psychological psychiatrists. So not only was it dropped, but it was dropped when it was the single most common psychiatric diagnosis at the time. And so neurosis is not a term that is used in psychiatry very often now, but this is how neurosis is defined in psychology. Anxiety, sadness, unhappiness, anger, irritability, mental confusion, a sense of low worth, phobic avoidance, vigilance, compulsive acts, lethargy, cognitive problems, ruminations, resentments, habitual fantasizing, and negativity and cynicism. I would suggest that there are a lot of people, and I'm saying people, not patients, who this definition or parts of this definition could be applied to. Would you go along with that?
Definitely. It's a very common sort of
They are very common
mental state that's been described there.
Yeah.
Next to those.
Okay. All of this now gets swallowed up by depression and anxiety. So how have these people been managed over centuries and years? Because people haven't fundamentally changed, and how are these patients now managed? So from antiquity, alcohol, cannabis, and opium have been used to manage neuroses, and neuroses taken broadly. And what I thought might be interesting is to run through what people have been taking since drugs and medications have been used. So alcohol, cannabis and opium. The 16th and 17th century laudanum, that was a mixture of opium and alcohol, particularly sherry, was used. 1826, bromides. Barbiturates came in 1903. Barbiturates were hugely used. Then chloral hydrate. Then meprobamate, which is a drug you may not have heard about, but this was hugely advertised in the States, and a significant proportion of adults were taking this. Then Librium, then Valium. These were very heavily promoted benzodiazepines. Have you heard of Quaaludes? So Quaaludes were a very abused drug in America in the 60s and 70s. And then on from there, you've got a whole bunch of other benzodiazepines. Xanax is particularly, has been particularly common, more so abused now in the United States. Then tricyclic antidepressants, and importantly, these medications were sedating. Then you had the use of antipsychotics, so chlorpromazine and stelazine. So you still see now stelazine being prescribed in small doses for the treatment of anxiety, so flupentixol. What's happened more recently, quetiapine has sometimes been referred to as the new Valium. Certainly there was a period where quetiapine was being prescribed for to lots of people for a wide variety of indications. It's certainly a very good hypnotic, and it's it's a very good anxiolytic as well. Then you've got all of the said drugs. Then tramadol was very widely prescribed from sort of the mid-90s onwards. The codeine preparation, both over the counter and by prescription. Then from the 2000s, gabapentin and pregabalin, initially launched for neuropathic pain, but then gained a license for the treatment of generalized anxiety disorder, and we'll talk about that later in this lecture. And talking to GP colleagues, MST, Oromorph are being increasingly prescribed, often initiated like fentanyl patches, by pain clinics, and often being demanded by patients as well. And what we see increasingly over the last 5 years are now patients accessing online pharmacies and the dark web. I've had a number of patients who've presented with oxycodone addiction from this. So why is this all happening? I would suggest that mental disorder broadly is overdiagnosed. Society no longer has the attitude that life is difficult. Society has the attitude now that there must be a chemical imbalance that needs to be fixed. All of these disorders, I think, are overdiagnosed, and there's an increasing demand for diagnosis. You may be interested to know how the Oxford textbook of psychiatry describes generalised anxiety disorder. And you can read what it says there, but since its inception, really, it's been problematic, and it remains one of the least reliably diagnosed anxiety or mood disorders. So how many patients are there that are being diagnosed with generalised anxiety disorder? Loads. And since it started, it's been problematic, and it's a diagnosis with very little validity. Is that something that you knew?
No, but it just seemed to be a very broad diagnosis.
Yes, yeah, it captures everything.
Yeah.
Everyone gets diagnosed, and then nowadays everyone gets given gabapentin to treat it.
Risky.
Very concerning. Okay, so last slide here. Chronic pain is also overdiagnosed, in my opinion. Fibromyalgia, again, is overdiagnosed. I would make the argument that the presentation is largely either psychological or social. I mean, how much of this, certainly in the older group of patients, is loneliness, and how much of this is a somatoform illness, and yet many of these patients will be prescribed chronic opiates. So I haven't offered many, if any, solutions, but I hope that was useful.